Thanks, Jennifer. Probably should have done this part before. So thanks for the introduction, and I'm just going to get clipped up here. And what I'm going to be doing today is really, I'm just the Chris Knobloch. I'm going to be introducing the all-star speakers that are coming up. I would say rock star, but the Billy Idol ad kind of ruined that for that joke. And we're going to talk about the Alberta SPOR Support Unit. So there we go. Some may be asking what SPOR-U is, or the Alberta SPOR Support Unit. SPOR stands for the Strategy for Patient-Oriented Research. And what is patient-oriented research? Well, it's a continuum of research that engages patients and providers, importantly focuses on patient-relevant priorities, and attempts to improve health practices or policies to actually improve outcomes. When we talk about outcomes, we're really talking about the outcomes outlined in the Institute of Medicine's quadruple aim. So improving patient health, population health, improving patient satisfaction, improving provider satisfaction, and/or improving the efficiency of healthcare. And really, the goal of SPOR-U is the achievement of an evidence and data-informed learning health system within Alberta. SPOR-U was funded by initially a $48 million grant from CIHR and Alberta Innovates. So it was a competitive process. Alberta was one of the first 3 provinces awarded a SPOR grant. And then in 2022, actually, we actually got it renewed with further funding. So we have a large amount of money that came in. We used that money to create infrastructure. So it's not an operating grant that can be dispensed to investigators. It was used to hire initially 64 staff members. I think we're at 48 right now. And those staff members are spread between the University of Alberta, within the Faculty of Medicine and Dentistry, and within the School of Public Health. So all within, and the Faculty of Pharmacy, so all within the College of Health Sciences. University of Calgary, largely within the O'Brien Institute, and within AHS, within Data Analytics and Provincial Excellence. And Jeff will tell us in a few minutes that name has probably changed, and it'll change again by next week. Our mission really is to bridge the gap between research evidence and healthcare practice by helping to design, generate, and implement patient-oriented research evidence aligned with health system priorities. And the key word there is the word help. So we do some of the research ourselves, but really our goal is to enable others, those in the audience, those online on Zoom, to actually design, generate, and implement these kind of studies. This is just a slide to show that everyone recognizes, every clinician and every patient has lots of ideas how to improve healthcare, how to improve outcomes. Fewer know how to design a study to actually prove that their idea would work. Even fewer have the resources to conduct the study. Fewer have the ability to disseminate the findings. And so as a result, all these great ideas, the Niagara Falls at one end, turns into a trickle at the other end. So recognizing that, CIHR established the SPOR infrastructure. There are now 11 SPOR provincial or territorial units. So every province or territory has one. And there are 7 national networks: mental health, primary care, chronic kidney disease, inflammatory bowel disease, chronic pain, and addiction mental health services, particularly for youth. So there are a lot of SPOR resources. Again, all the SPOR resources are infrastructure, so it's to hire existing staff, not available as operating funds. And really, CIHR is emphasizing that we need to address the gap between science and practice that we all recognize. It's been said it takes 17 years for research to reach practice, and only about 1/7 of any research finding that is of significance actually touches patient care. So what were the goals of SPOR-U? So we were set up in 2015. We actually got awarded the money in 2013, but it took 2 years for all the legal agreements to be settled between the provincial government and the federal government. So in phase 1, we were building capacity, capabilities, and partnerships to increase the amount and the quality of patient-oriented research being done in Alberta. In phase 2, we've really focused on trying to achieve some demonstrable impacts within the learning health system and help catalyze the AHS learning health system. Our partners in phase 1 were principally Alberta Innovates, CIHR, and the universities. Within phase 2, we've been much more closely linked with Alberta Health Services, with the Physician Learning Program, with Epicor, Wickery, the Centre for Health Evidence down in Centre for Health Information down in Calgary, and also the physician learning program and the top programs from AMA. What are the components of SPOR U? Well, you're going to hear in the next 30 or 40 minutes about the 3 research services that we offer to any investigator based in Alberta. In patient engagement, learning health system, data and services. We'll also tell you a little bit about our capacity development portfolio, and we offer graduate studentships of up to $30,000 a year, and we fund between 12 and 14 applicants a year. We have about 50 to 70 applicants per year. So that's just a schematic showing what we'll be talking about. So Dr. Bakel will be talking about the data and services portfolio, and we support primary data collection studies, a lot of secondary use data studies, and increasingly AI studies into the electronic health records. Dr. Stephanie Montesanti will be telling us about the learning health system and the supports that are available there. And then Kelly Buckroyce will be telling us about capacity development and patient engagement. So you may say that sounds great in theory. Has it actually worked? Well, so far in the first 9 years of SPOR U, we've had more than 3,000 requests for research service support. So far, we have a 94% approval rating for those that like social media from individuals who have asked for support. As Dr. Bakel will tell you, the timelines to access data in Alberta have gone from 3.5 years in 2013 to about, on average, 7 weeks, I think it is now, in 2024. So that's actually comparable and better than many other provinces now. We'll hear a little bit about the graduate studentships program. We have funded 118 graduate students so far. We've provided more than 650 in-person or online training opportunities thus far within SPOR U. So you may ask, who are the clients? You can see on this schematic, most of them are academic researchers, so folks like those in the audience and hopefully online. In the dark purple, you can see that those are requests just for data or data research services. So that can include actual analysis of the data if individuals need that. And you can see that most are academic researchers, most from the University of Alberta or the University of Calgary, smattering of folks who identify primarily as AHS as their home. This slide is just to remind people that it's not just data access, extraction, linkage, and analysis. There have been requests for help with knowledge translation, health system research, which Dr. Montesanti will tell you about, patient engagement, planning, recruitment for trials, and then also research design, data management, and analysis. We've supported a number of successful PRIUS grants and CIHR grants. If you want to avail yourself of the services that you're going to hear about in the next half hour, I'd encourage you to go to the website, absporu.ca. And if you click under Research Services, you'll see Service Application come up. You can click Service Application, and then there's an online form to complete. It's a relatively easy form, particularly if you're ready on your ethics. You basically can just cut and paste and fill out what you specifically need help with. We do ask that if people are filling that out, make sure you click off the required support. If you leave that part blank, we don't know where to funnel the request. Once you've completed the form, it goes to the central intake process, which is run by Alberta Innovates. Because this is Alberta Innovates funding and CIHR funding, the requirement for support is that the investigator has to be based in Alberta. And if it's a access for data or research services, there has to be a completed ethics application. So if those are in place, Alberta Innovates will give it the check mark and then pass it along to Yazid, who's in the audience here. Unfortunately, I can't see online Yazid, but so he's looking happy. And the request will go to Yazid to kind of look through the request and decide where to filter it. And he'll send it to the patient engagement team, the knowledge mobilization and implementation team, or the data and research services team. And somebody from that team will then reach out to you and define the request and then start working on that once it reaches its place in the queue. Right now, it's a first come, first serve kind of application. We do like people to be fairly responsive. So if you get the email from the data and research services statistician asking some questions, please answer it fairly promptly, because we have some people that wait 3 months to answer it and then send me a complaining email saying, I sent a request in 4 months ago and I don't have my data yet. So there has to be some quid pro quo, and we do ask that people be fairly responsive when the requests come in for clarification. You can also come in at what's called a prefetch stage, or before the data request, to actually ask Yazid for advice on setting up your project and how best to do that. And we'd encourage people to use that if you feel the need. So in the next half hour, the other three speakers, the rock stars, are going to talk about key support for researchers available here in Alberta. Our first speaker is Dr. Jeff Bakel, who's the Program Director for Provincial Research Data Services at Alberta Health Services, and is co-lead of the SPOR Data and Research Services team. Jeff, I'll turn things over to you.
All right. I don't think Finlay had this thing on.
It's just a little bit.
I'm just gonna kill it. Yeah, so a bit about our team. So overall we've got right now within our group, so we're basically, as Finlay mentioned, we're located in Alberta Health Services. We've got a team called Provincial Research Data Services, and in there we've got 37 analysts currently, about half and half split between PhD and master's level folks. Yeah, we do about 200 projects a year. Again, similar to what was mentioned, most are with the U of A, U of C researchers. About half our projects are delivered within about 6 weeks from the initial contact. A lot of the delays are, again, it's kind of gone up a bit in the last little bit, just as we get into more connect care analyses and that kind of thing. The complexity of the project goes up, so it takes a bit more time. Last year we had 55 publications, and we've got 6 active pragmatic trials going that we're doing recruitment and outcome for right now. And then we've been working with the other provinces through the other SPOR networks through the HDRN. So I'll talk just a so through the SPOR support, there's been this health data research network that's been established. And basically that's the set of SPOR data platforms across the province. And so that's given us some capacity to do interjurisdictional research, both in figuring out things like algorithm development so that we're all talking about the same thing across the country, and then developing some clinical trials and some guidance around data privacy and that kind of thing. So for our data, we do a lot of secondary data from what's called the administrative or health services data. So a bit about where it came from, like where the data comes from. Basically, if we have this sort of imaginary person, Mary, she moves to the province from Manitoba. When she gets here, she gets assigned a provincial health number, and in our case, a unique lifetime identifier. And that kind of provides the basis for all our linkage that we do through the system. And so down the road, maybe she visits a general practitioner. That billing information goes into our claims database, so we get things like a encoded diagnosis, any procedures that were done, and the billing amount. And then she got a prescription, she fills it, it goes into PIN, which gives us all the medication information, lab work. And then down the road, if she goes to an obstetric clinic, let's say, it gets coded in our outpatient data and into Connect Care now. And so, through all these things, we kind of build this inventory of data around each person. And so, she gives birth in the hospital. We get all the dates, locations, any procedures that were done, and, a new EULI. And so then, we get lots of data about the baby as well. And down the road, if she calls HealthLink about something, those 2 records are linked and in the system as well. So overall, it kind of creates, our what goes into our data enterprise data warehouse. So we've got our hospitalization data. We link in some of the long-term care data, EMS, the providers. Using census information and postal code information, we can link it with get some estimates of socioeconomic status, and then some of the other stuff that we've described there. So when we're looking at projects, the things we're really looking at, especially as we kind of move into a lot of machine learning, artificial intelligence types projects, is we've kind of trying to adopt this 5 SAFEs framework. So when we're considering things, we want to be, thinking about, are the data safe, that we're protecting confidentiality of people? Is the project safe, right? Are we doing public good with this work? Are all the researchers trained appropriately? So we've got our safe people. We're working with to create secure environments for the data analysis. So we have a system here, the dark system we've been working with, and I'll talk a bit about our Snowflake stuff in a minute. And then safe output. So whatever data we're putting out, it's been screened and approved to be non-disclosive. So what people ask for a lot, basic data extracts. So it could be anonymized data about a condition or people in the province. As the data have been more complicated, we start doing a lot more analyses in-house, just because we've got our folks who are experts in working with the data. Kind of branched out into doing some patient identification and recruitment for various studies, doing some outcomes work, and again, sort of especially with our pragmatic clinical trials, and then some methodology work around case definitions and methodology for working with this type of data. So in data and analytics, in AHS, we've been modernizing our data warehouse to a Snowflake environment, which is just a cloud-based data warehouse. And so what that allows is basically data sharing between ourselves and, we're working on one with Alberta Health right now and other organization, and even within organization, I should say, and building out some common data model stuff. It gives us the capacity to do some secure computing in-house so that, we can build a model inside the framework. It's all sort of compute as a service. So if we need to basically rent a GPU by the second for anything that's needed. And then we're looking to kind of branch out to be able to bring in some external data sources to bolster what we can use for research in the data warehouse. So what's next? Yeah, really, we want to evolve the use of the data that's in Connect Care. We're still getting the data quality is getting better over time, and our use of it is getting better. Really developing our Snowflake infrastructure to be able to do more intensive work and get better access to data, and then really working to integrate the data and the results back into the healthcare system. And so with that, I think I will turn it back over. I'm not sure why I did this.
Okay, so thanks, Jeff. Our next speaker is Dr. Stephanie Montesanti, who's a Tier 2 Canada Research Chair in Health System Integration. She's an Associate Professor at the School of Public Health, runs the CARE Lab over the School of Public Health, and is also co-PI with the Indigenous Primary Healthcare and Policy Research Network, and is a Women's Health Research Ambassador for the Alberta Women's Health Foundation. So I'll let Dr. Montesanti tell you about the knowledge translation and learning health system team. You said.
Great, thank you, Finley. Maybe I don't need this. Okay. Okay, welcome to everyone in the room and online. So I'm one of the newest members of the SPOR U team. I'm the academic lead for the Learning Health System team, and I'll tell you a little bit about what we're doing. Okay, so I'm going to tell you a little bit about what our Learning Health System team is doing and the types of services and supports we provide. So I wanted to just start by explaining what a learning health system is. So a learning health system is a framework that promotes rapid cycles of learning and improvement for best practices in healthcare delivery. Implementation science and practice is an important component of the learning health system. So we do provide a lot of support and resources for implementation to support rapid uptake of evidence, best practices, to support interventions in the healthcare system, including knowledge mobilization supports for researchers and clinicians within the healthcare system. So we've been supporting teams. We've been providing embedded research support for teams related to knowledge mobilization, which includes walking them through a knowledge mobilization plan, identifying key knowledge users that would be intended users of the evidence and the research, and so providing practical implementation guidance. And this includes tools and again, embedded research support. So we do have implementation scientists on our team who work closely with teams who are looking for implementation science support. And implementation science is really helping us to understand what interventions work, in what context, and in what settings, why, and how. We're also supporting teams in assessing their readiness to implement a new intervention or program or service, and evaluating those implementation interventions. And that has played an important role for teams or programs that we've been providing more longer term support for. And additionally, we are always interested in learning about the learning health system field and new approaches and methods in implementation science. One emerging area that our team has been really excited about is the integration of equity in implementation science. So we provide consultations or longer term support, and those consultations can be, one-off conversations with a team or walking them through their implementation journey and providing more longer term support for those teams. Capacity building, and I'll talk a little bit about the implementation science certificate program that we provide, and the implementation science collaborative. So in terms of consultations and project support, as mentioned, this can be short-term consultations, which may be, support within the grant writing phase, with grant reviews, single conversations, including providing support around implementation science methods or evaluations, helping to inform their study designs, or identifying who may be key actors, key stakeholders within the healthcare system that you may want to engage or work with in your project. And here are some examples of longer term supports that we've provided over the years. One that you can see listed here, which has been one of our signature programs that we've been supporting over a few years, is the Acute Care Bundle Improvement Initiative. And this program is really about bundling best practices to optimize healthcare delivery. In terms of capacity building, we've been offering an implementation science online certificate. And the next offering for this will be in fall 2024. The past few iterations of the certificate has been offered to strategic clinical networks within AHS. And we really bring in some valuable insights around implementation in terms of theory and practices, and align with real-world practice insights. The Implementation Science Collaborative is a mechanism to integrate health system, academic, and SPOR expertise. And here is really a space for us to think strategically about spread and scale, as well as sustainment of healthcare innovations. So it has been a space for us to really explore more in depth different innovations and more tailored support for those healthcare teams who are innovating in the healthcare system. So as mentioned, really about exploring how to facilitate spread, scale, and sustainment of innovations within the Alberta healthcare system. And as mentioned, it brings together leaders from various healthcare communities, and we are tapping into their practical knowledge and expertise. And really taking the time to think about what are the implementation barriers as well as opportunities when we think about spread and scale. Implementation can be challenging, and so understanding context has been really important. A lot of our conversations have really been about understanding those contextual factors that shape or influence how we implement innovations in the system and where the opportunities are for spread and scale. So in terms of the who, we are examining those practical barriers and developing implementation research designs and measures to embed in health system innovation projects. Okay. And then we take a lot of that knowledge, collective wisdom that is shared in the collaborative to promote these research recommendations, identify well-suited project teams, support with knowledge brokering, coordinating data capture and analytics, and cataloging our lessons learned to inform future implementation province-wide. So what's next for the Learning Health System team? So we've been really interested in better learning what other teams are doing in the Alberta healthcare context. So we've coined this term around learning health system sites, and what this really suggests is that there are healthcare teams out there that are doing fantastic work and really have been integrating best practice evidence, experience, external evidence to support those rapid cycles of improvement and learning. And we want to know, how are they doing it? And how did they get those innovations off the ground? And how can we see those as sites and champions and to learn from them? So this would be a space for these sites to come together to problem solve, identify how we as a team can better support their learning health system initiatives. Additionally, we're looking at training for learning health systems. So as a field, what training can we provide for orienting clinicians, healthcare teams, researchers in the learning health system field? So we are exploring the feasibility and opportunity of implementing an online short course. Supporting learning health system fellows. There are fellows, researchers who are working in this space, and we want to know who they are and how we can really build their competencies and skills in learning health systems. And yeah, I'll end right there. Thank you.
Great. Thank you, Stephanie. So our next speaker is Kelly Buckroyce. Kelly is the Executive Director for the SPOR U, kind of functions as my right hand. Not in the Game of Thrones way, but in a more traditional way. She has 20 years of experience in program management and community-based participatory health research. She holds bachelor's degrees in bioethics and medical anthropology, master's degree in education leadership, and is currently working on her doctor of education degree, exploring how better to modernize continuing health education. So I'm going to turn things over to Kelly here to talk to us about the patient engagement and the capacity development portfolios.
All right, so I'll start with our PE team, which is led by Dr. Maria Santana and Dr. Paul Ferry. The PE team provides ongoing support to patient partners, researchers, and works with community organizations to identify research priorities and to help these partners to collaborate in active, meaningful ways on health research studies. Our PE team is a multidisciplinary team with a diversity of expertise, and one of their key activities is facilitating a provincial patient partner council, as well as a network called Albertans for Health Research. There we go. Albertans for Health Research includes an online network that connects health researchers with citizens who are interested in contributing to research that matters to them. And the website is a source for all current opportunities in health research. Researchers can post their opportunities there, and citizens can go to the website to find available opportunities. And we recently launched a new Instagram page, as you can see here, to help raise awareness and share outcomes from projects we support. And you can follow us at AB4 Health Research on Instagram, and the website address is up there. And you can also connect to Albertans for Health Research through our abspur.ca website. All right. So what do we mean when we say patient? We mean individuals and their informal caregivers who have personal experience of a health issue, and also their informal caregivers as well. And this definition is from the CIHR SPOR patient engagement framework. And depending on the context of patient-oriented research, this may also the research may also engage people who bring the collective voice of specific affected communities. Right. And in patient-oriented research, we're talking about patients who are engaged as equal members of the research team. So this is very different from patients who are being engaged or recruited as research subjects. So patients as research partners working as part of the research team. And that engagement must be meaningful. And what this means is inclusiveness, support, mutual respect, and co-building. So we look at the scale on this slide, and you can see that there's a spectrum with meaningful engagement increasing towards the right-hand end with collaborate and empower. Patient research partners may be engaged in activities such as priority setting to inform research questions, conducting research, knowledge translation, and as well governance and decision making. And I wanted to mention that our own executive committee does include two patient partners, and they contribute to the decision making for our unit. Patient research partners can be engaged at any and all appropriate points in the research cycle, from developing the research question and study design, all the way through to dissemination. And some benefits to researchers that patient engagement can provide include such things as more relevant research questions, better research design, increased participant recruitment, and decreased attrition. Wider impact and application of research findings, and as well better insight into gaps and priorities in research areas. So how does the PE team support researchers? They provide pre-consultations and consultations where they discuss your needs and finding strategies to support you. They help with sharing ways to include essential patient insights and perspectives into your project. Identify and support non-tokenistic engagement of patient and community members for your project. Sharing supports and resources available to do so. Supporting and advising on the patient engagement aspects of your grant writing. And they can help with recruitment through patient and community partners, providing that support as well. And supporting establishment of patient advisory groups, and supporting for evaluation of the engagement experience for both the patient partners and for the researchers. So our patient engagement resources can be found both on the absperu.ca page, as well as on our Albertans for Health Research.ca website. And there you can find our co-developed patient partner compensation guidelines, ethical considerations, evaluation tools, publications, as well as our previous journal club articles, podcasts, webinars, and a link to our social media and YouTube accounts. You can find information about our Accelerator Award, which supports the early engagement of patients to help inform research priorities, and much more. Our PE team works with communities on projects that matter to them. They help identify and prioritize relevant research questions, as well as building research capacity and creating mentorship opportunities in diverse and valued communities. And this is one example. The Immigrant Youth Mental Health Project aims to identify the unanswered questions about youth mental health in Alberta's newcomer communities. And the results of this priority setting project can help guide future research, be available for mental health advocacy, and serve as a framework for future collaborations. The results may also help inform more culturally appropriate mental wellness policy and practice. And I'll just end by highlighting the PACER program, which stands for Patient and Community Engaged Research, PACER. And it's a training program that's co-delivered by our patient engagement team through the University of Calgary Continuing Education. And the aim of this program is to train patient research partners on research methodologies so that they can have an even more active role on research teams. Okay, so moving on briefly to our capacity development team. This team is led by Dr. Elizabeth Adon-Palucci and Chloe Burnett, who are located at the University of Calgary. The objectives of this team is to provide high quality training opportunities in patient-oriented research for diverse audiences, including for patient partners, directly supporting research trainees in patient-oriented research through Studentship Awards program, collaborating with partner organizations to offer innovative patient-oriented research capacity development opportunities provincially and nationally, fostering the inclusion of patient-oriented research training broadly in formal education contexts, I can never say that word, contexts, and contributing to research on program improvement and capacity development innovations in patient-oriented research. In line with our mandate from CIHR, our capacity development initiatives provide inclusive training opportunities that aim to engage all research partners, and that includes patients. All right. So our programming comprises three main areas: our certificate programs and microlearning, formal learning and trainee support, and events and collaborations. So for instance, our certificate courses include patient-oriented research fundamentals, implementation science, as Dr. Montesanti described, patient engagement, data for health analytics, pragmatic clinical trials, equity, diversity, inclusion, and accessibility. And there's also many free e-learning modules on these topics available on our website. We also co-deliver 2 4-credit graduate courses, one through the U of A School of Public Health and the other through Community Health Sciences at the U of C. And I'll also mention that Yazid in pharmacy teaches an Intro to Pharmacy course that has a large component in patient-oriented research. And I'll mention as well that graduate students throughout Western Canada through the Western Deans Agreement may enroll in these courses, even if they're not registered at the U of A or the U of C. We also have our annual Collaborative Forum Conference, and we collaborate with partners in Alberta and nationally on various training initiatives. And there's a lot more information about all of this on our website. And I'll just end by highlighting our very popular graduate studentship in patient-oriented research, which provides, as Dr. McAllister mentioned earlier, a 1-year studentship that provides $30,000 in funding, along with comprehensive supplemental training in patient-oriented research. And the idea behind this program is that it provides embedded training within Alberta's learning health system. We've also been in discussions we've been in discussions with the medical schools at the U of A and U of C regarding establishing a 1-year clinical traineeship, whereby a $15,000 ABSPOR award is matched by the department, and funding can be combined with other awards up to $80,000 in total. And please visit our website if you're interested. There should be more information about that available soon. And I think with that, I'll just go on to this slide to acknowledge our funders, and I'll turn things back over to him.
Great. So thank you, Kelly. So the point of today was really just to bring information to the department in the hopes that it would stimulate some increased, not increased work for us, but increased inspiration. I would encourage people to go to the website. There's a lot of information on the website. There's, as Kelly mentioned, there are even e-learning modules, so you can click on, find out what a learning health system is, what knowledge implementation is, what patient engagement is. So there's a lot of information there. There's also a lot of information on what data sets are available, and I think it's up to, is it 67 data sets, Jeff, that are available in Alberta that can be linked most of the time with ethics approval. There's some data sets that aren't held by Alberta Health Services, that are held by Alberta Health, and that requires a slightly different process. But again, Yazid will help to navigate you through that process. And our data and research services team now have very good links into Alberta Health to access some of the data sets that Alberta Health holds that Alberta Health Services does not. So we deliberately wanted to have a lot of time for questions because we thought there would be questions. Certainly, there's a lot of emails that come in. So at this stage, I'll maybe throw things open for questions. And
Thank you so much for the outlining all of the amazing things that the AB SPOR unit can do. Do you want to?
Yeah. So a couple of questions came in chat. One was a question about, are the personal health numbers and the ULIs the same thing? Yes, they are. They're the unique identifier that all of us are assigned when we arrive in Alberta. And they are the same across data sets. Again, when the data is released to investigators, it's released in de-identified form. So you don't get actual dates of birth, you don't get names, you don't get actual addresses. And you don't get actual PHN numbers. You get the first 3 digits of the postal code, year of birth, those kind of things. But it is de-identified data. The second question was about today being National Indigenous Day. What measures are being taken to include First Nation patients, including working with the U of A Vice Provost Office on Indigenous Research? So that's a good question. One of our PACER cohorts that Kelly mentioned was actually Indigenous investigators from rural or non-metropolitan sites. And one of the key implementation science activities has been around, I've forgotten the name of Métis Primary Care Initiative, again, which is outside the metropolitan areas. So we do have input from the Indigenous research groups at the University of Alberta and the University of Calgary in our steering committee for the Alberta SPOR Support Unit. So there's another question. Are research trainees from overseas eligible for studentships? They are eligible if they're going to be in Alberta for the studentship. It can't be a check written and sent to another country. The student has to be here, and the investigator sponsoring them has to be Albertan, with a faculty appointment to the University of Calgary, University of Alberta, Lethbridge University, Athabasca University. Another question, are patient partners selected and are they paid? So for participation, patient partners are paid. That's CIHR policy. They're paid at the rate that CIHR has mandated for all patient partners, and that's the same rate across provinces.
Any questions in the room?
At the very beginning, you gave the widely held quoted all the time, 17 years from research implementation. That reference is now a quarter of a century old.
Yeah.
Is it still true, or have we got better? And if not, why not?
Yeah.
Maybe we can repeat the.
Yep. So the question from Dr. Gibson was the widely quoted 17 years till research hits clinical practice, and only 14% of research actually influences practice. So you're correct. That's a quarter of a century old. I'd like to believe it's better. No one's actually repeated the study. The encouraging thing is if you look at things like the recovery trials that were done for COVID, that was, a year and a half from initiation of the study to results to actually widespread change of practice. So I think in certain situations, it can go faster. Unfortunately, a lot of situations, it still doesn't. And that's why CIHR has put money into things like the strategy for patient-oriented research to try and address those gaps. I will editorialize that one of the reasons that the HDRN, the Health Data Research Network Canada, was created was recognizing that Canada didn't do as good a job as the UK did. We didn't have a recovery trial. We had a number of other small COVID trials that weren't quite as large. A lot of them were ICU based. But we weren't as successful in being able to pull administrative data for outcomes from each province because, as everyone knows, healthcare is a provincial responsibility, and the government, like different governments, have put in things like the Health Information Act, where we can't send Alberta data to some central site in Ontario or BC for them to analyze the data for every province. So that was a limitation that the UK didn't have, and that allowed them to do the recovery trial so well. So the hope with the HDRN is that pragmatic clinical trials going forward will be able to extract outcome data from routinely collected administrative data and be much more efficient and more responsive. Other question?
Sorry. Thanks for your presentation. I have a question about the ICD coding algorithms. Are they freely available online, or how do we get access to them?
Short answer is there's some very good published papers that have actual ICD coding algorithms that have been validated in Alberta. So there's about 30 conditions, the most common things, particularly around cardiovascular, endocrine, and renal diagnoses that are available. For other coding algorithms, if you speak to Yazid, he'll put you in touch with the Data and Research Services team. They have a lot of the macros, the SAS macros for a number of case definitions. So when there's a validated case definition, Jeff's team has already incorporated it. If it's a brand new condition that no one's asked about before, we may ask the PI to go back to the literature and find a case definition that's been validated somewhere, ideally in Canada, and then we'll apply that in the Alberta data. Sorry, Jeff. Yep.
Yeah, there's also on the HDRN site, so we've got an algorithm inventory for the sort of a national one. So if it's been published and validated in Canada, hopefully it is there or will be there.
Can I just follow up? So is there a plan to validate it in Alberta concurrently with that project, or is that a discussion with the PI level, or do you just assume that it's validated?
Most cases we would, if we have a good validation, I mean, some of them we've done everything from, do a simultaneous chart review to what's in the data, so again, it really depends on the condition, right? Others we've already, right, if it's been done and it's good, then deal with it.
Yeah. And Kathy Eastwood's pointed out online that the Centre for Health Informatics at the University of Calgary has compiled a list of validated algorithms that I'll maybe ask Kathy to reply via chat whether it's actually available yet or not. Once it is, I'm sure we'll have a link from the AppSpor-U website. Dr. Vithanagam online has asked for, can AppSpor-U help with acquiring lab policies for ethics approval? I suppose the answer is it depends what exactly you're looking for. What we do ask is that PIs do their own ethics approvals. If there are questions, then we ask people to put in a request for a consultation with Yazid. AppSpor-U pays for the consultations because we pay at least part of Yazid's salary. So there's no charge for those consultations at this time. Moving forward, depending on what CIHR does, and CIHR is under a budget crunch, as is Alberta Innovates and everyone else, there may be a charge going forwards where currently we'll charge for data extraction. We charge a fee that's actually just the time for the data analysts. We're not charging server access time. We're not charging server maintenance time, which those who've done studies in other provinces will know it's fairly commonly assessed. So you're actually just paying for the time that the analysts put in.
Dr. Bello has a question.
Okay. Thank you very much, Dr. McAllister and the team for this great elaborate presentation. This is highly commendable. Personally, as an investigator, I have a very, very positive experience with Alberta SPOR. Have been very highly supportive, very responsive. I met a lot of friends here, including Yazid, so this is very positive. I benefited, and I know a number of people who have directly benefited from this initiative. So the first question I have, this is very critical research infrastructure we are fortunate to have in this province. So what is the sustainability plan? What is going to happen after the year 2026, for example? And my second question, I'm very impressed also regarding the capacity building, which focus on the trainees. So I wonder also about the evolving or early career investigators. What sort of plan do you have? They come mainly, all come as early career investigators without, any funding or very little funding. So if there are charges to project, what is the support available to them to help them, grow in their career in terms of mentoring, in terms of training, and helping to provide them with resources, to get their project off the ground and be successful. My next question is related to the question posed there regarding the indigenous engagement. I don't know whether we can make that more visible, because this is very obviously important for us in the province, important for us in Canada. One of the most challenging issues regarding indigenous health research, obviously, is community engagement, getting communities involved. So probably we want to see that more visible support, resources available to the researchers interested in the field on how to navigate, how to collaborate, engage with indigenous communities, and also other disadvantaged groups like ethnic minorities, sexual minority, research, immigrant health, and so on. So that's also perhaps needs to be more visible. I know it's ongoing, but needs to be, more visible and elaborate so that people will know that kind of support is available. But lastly, thank you for all you do, and we really appreciate all the support being granted to all of us under our trainees. Thank you.
So thanks, Dr. Bello, and your thanks is really directed at Jeff's group, Stephanie's group, and Kelly's groups. So I think the first question about early career investigators is an excellent one. I do encourage, certainly our graduate studentships support very early career investigators who are looking at whether to get into the field of clinical research, health services research, patient-oriented research. The unique thing I like about our graduate studentship program is of the 14 reviewers on the panel, 7 of them are actually patient partners, representing diverse ethnic groups, diverse viewpoints. And so if you go back and look at the 118 graduate studentships that have been awarded, it's actually a really nice breadth of topics. And covers a lot of issues around EDI. So that has been something that certainly the patient partners have brought to that review process in a much more authentic way than my experience with patient partners with CIHR or heart and stroke, where it's kind of, I read the lay abstract and okay, we'll let people do. So it's much more, I think, engaged in that process, so much further to the right side of the slide that Kelly showed. For early career investigators, we have had discussions with NARMN, so the Department of Medicine will be establishing a clinical scholar program for folks that are finished their fellowship program, their clinical fellowship programs, and then have 1 to 2 years of additional funding, partly funded by SPOR, partly by this College of Health Sciences, to get extra training and do a master's or a PhD in patient-oriented research. And patient-oriented research, again, it's something around patient-identified priorities. So it doesn't have to be pure patient engagement, but it be something that, the excellent example is what CanSolve CKD did about identifying, the big patient issue in dialysis was pruritus or itchiness, not creatinine levels or some of these other things. So that's an excellent model that we kind of look at as an inspiration for the way that we would hope this would happen. For early career investigators who already have their faculty position, we have had some folks enroll in some of the certificate programs. I think it's been really useful. From my perspective, it's nice to see. We've even had one divisional director enroll in one of our certificate programs. And he came back and said he learned a lot he didn't know about the data sources that were available in Alberta. Because the thing is, a lot of people assume we don't have access to data, and we do. And it's one of my great frustrations. People say, "Oh, I would do this, but we can't access that data." That's 2015 thinking. That's not 2024. So we have as good or better access than most provinces. in terms of, so there's a lot of e-learning modules that early career investigators I would encourage to look at. And Yazid does a very good job as well of identifying, here's an early career investigator, trying to put them in contact with some more established investigators in that field. I will admit that if we have an early career investigator, we tend to give them a little bit of a break on the costs for the data and research service access. If it's a more established investigator, like I get a bill from Jeff's group every time I pick up the phone. Whereas, yeah, I know. It's like a lawyer or something. So the more established you are, the bigger your bill is going to be, recognizing that more established investigators have a bit of a slush fund. We also ask investigators when they're putting a grant in to actually include budgeted items for data access, data linkage, curation, collation, cleaning, analysis, rather than just adding $10,000 on at the end, and that gets cut by CIHR anyway. So there's an actual budget that Jeff's group can provide, or Stephanie's group if it's around a knowledge implementation, saying here's the actual cost, and then that is built into the grant. So we ask people to do that going forward. In terms of sustainability, that's our plan, that eventually this would be self-sustaining. To be self-sustaining, it does require input from investigators. So in some ways, some of the more established investigators will be, some of that money that's going in is going to be supporting some of our younger colleagues coming along so that one day we can retire. The second question about Indigenous engagement, excellent question. As I mentioned a lot, we have funded a specific PACER group on Indigenous patient partners. We have Indigenous patient partners in our steering committee. Dr. Montesanti is probably better able to talk to that question as well, but since she's the co-lead for the Indigenous and Primary Health Care Policy Research Network, and maybe I'll ask Stephanie to, yep.
I think we're at time.
Well, I just quickly comment, because
Okay.
I did mention that our learning health system team is applying equity-oriented implementation science frameworks as an emerging area. So there's been growing scholarship on integrating health equity principles in implementation science and practice. And in that scholarship, there's been that application with Indigenous communities and collaborators. And that brings in community-based participatory research practices in terms of community engagement, right? And thinking about Indigenous methodologies alongside implementation science theories and frameworks. So it's certainly a growing area of interest for us and a priority, and something that we want to explore going forward. So thank you for bringing up that question.
Thank you to the team for such a fantastic overview on all the amazing resources that are available to our department members at the AB SPOR unit. And with that, that is the closing of the Medicine Grand Rounds for this academic year. And we'll see you all in September.
September 13th.
September 13th.